Good afternoon. Welcome to Samaritans International Health Forum. Thank you for joining us. We hope you all participate in the conversation today. You can chat with us in the chat box beside the video. Before we begin, let's open in a word of prayer. Dear Lord, thank you for this day. Thank you for the wonderful sunshine here in North Carolina and the opportunity for Dr. Bowl to share with us. Thank you for this opportunity for us to learn and chat together. Help this be a useful resource to all those participating and those who will follow us in the future. All this we ask in Jesus' name. Amen. Well, as I said, Dr. Dan Bowl is with us today presenting basic urology with limited resources. Dr. Bowl has been a practicing urologist since 1980. In 1980, he started a busy surgical urology practice and was continued that in Columbus, Ohio until 2008. Over the last 12 years, Dr. Bowl and his wife, Bridget, have been participating in multiple short-term medical missions in a variety of countries. During this time, Dr. Bowl has also maintained a small primary urologic practice here in North Carolina in the town of Edmonton. Dr. Bowl, good afternoon.
Hello. Are we with me?
You bet.
Today I'm going to discuss basic urology with limited resources. Can we have the next slide, please? Okay, there we are. First, we're going to talk about the problem and then the resources and the setting. Basically, how to solve the problem with the available resources in a particular setting. I hope to have something useful for any medical missionary, from basic medical providers to general surgeons or even experienced urologists. Next slide. So setting. We're going to look at some of the different settings in which I've worked to get this experience. They vary from primitive health clinics to mobile hospitals to fully equipped centers in primitive areas. And next, I'm going to run through some of the places we've been in the past 12 years so you can understand how I've developed these insights. Next slide. Haiti. This was a very primitive area in Haiti. We had to hike in with our supplies. There was no modern technology, no running water, no electricity. We slept in tents. All we had as far as urology goes was history, physical exam, and some urine dipsticks. We had some antibiotics to hand out. So in an environment like this, our real focus was sanitation and nutrition. And what you see is the area in which we stayed, a clinic in which we saw some patients. Next slide. And this is some more pictures from Crochu, Haiti, where we were working. This is the main road in town with some little stores. This young gentleman who's pictured was, as you can see, malnourished. But when we gave him some food, he split it and gave it all to his younger siblings. His parents were both gone, and he was the head of the household. And the third picture is just a picture of the flatlands from up where we worked. The patients that we took care of in this area really never left the area, never got to town. They never went more than a day's walk from where they lived. Can we have the next slide? This is a health clinic in San Juan, Bolivia. This is a tiny town. The main road was about a block long and it had some stores along it. This is a public health clinic where we saw some patients, very few resources. We also leased a hospital in that area that had been built by the Japanese after World War II. The hospital did have a small operating room, but they really didn't have any staff or equipment or anything else. Theoretically, the patients could have gone to Santa Cruz, which is about 2 hours away, but in reality, they had no ability to pay for services and they had no transportation. So there was really nothing else for them. We have the next slide. This is a mobile hospital in the Dominican Republic. Everything we needed for an entire surgical hospital was on this truck. We brought our own staff and supplies. We took care of patients during our 2-week project there and left nothing behind for the future, unfortunately. The mission truck did return about once a year. In this location, we did about 140 minor operations and some major operations in a 2-week period. This points out one of the big problems with these short-term missions. What we do is leave nothing behind. So after we're gone, there's no health care until someone returns. Can we have the next slide? This is a small public hospital in Ambato, Ecuador. In Ambato, we had some really good general surgeons. All the physicians were government employed. They said that free care was available to everyone, but there really wasn't any care to have. The reality was there were no supplies. Treatment was determined by kickbacks and corruption, and nobody really got any care. We went there and leased this space and worked with some really good general surgeons. And our mission there was to teach them certain types of operations that they could use after we left. Next slide. And this is Soto, Ethiopia. This is a very primitive area, as you can see, but the local resources in the hospital are really pretty good by Africa standards. On the left, we see Bridget on the hospital grounds. They did have some good general surgeons in this hospital, and they had Pan-African Association of Christian Surgeons residents. They had some basic donated urology instruments, but no one knew how to use them, so they just sat in storage. And on the right is what they called their ICU. The sawdust you see in the bucket is to be thrown on the floor when someone vomits, and this is an old suction machine. We have the next slide. This is the town outside of the hospital complex, so that you can see how the people live there. And also I have a picture of Bridget. She was teaching the nursing staff how to take care of patients in the ICU and recovery room. We have the next slide. Portachuela, Bolivia. It's about an hour-and-a-half drive from Santa Cruz. They had a nice little public hospital there, but they didn't have any equipment, supplies, or regular staff. When we went to Portachuela, I took my own urology instruments, and we started to do some transurethral surgery with those. It was quite interesting that when I went through customs, the officials required me to register those instruments, and they made sure I took them with me. They didn't want any instruments left behind in their country. I think they probably thought they'd be sold or something of that nature. Next slide. And these are some more pictures from Portachuela. It's the entrance to the hospital. These are some of the supplies we used. The bottles of distilled water we boiled in a big container on our stove and poured them back into these containers so they'd be sterile. And that's what we used for irrigation for transurethral surgery. And also that piece of equipment is what they had for an autoclave. Next slide. This is the portable anesthesia machine that we took to Portachuela. You see one of our volunteers packing some sterile supplies. And then there's a line of people waiting to be seen there. Next slide. So now we're going to talk about resources. And when we discuss resources, I like to think in terms of the skill levels of the physicians and the staff first, the available technology, and then not forget the options to refer patients elsewhere for care, which generally doesn't work out very well. Next slide. These are some of the common problems I'm going to discuss. Urinary retention, bladder stones, urinary tract infections, kidney stones, testicular abnormalities, abnormalities of the penis, trauma, and cancer. Next slide. And the general principles with each problem is first, understand the problem, understand the risks and consequences of your actions, and understand what's going to happen if you fail to act. Be aware of the resources, how they can be used to help, and always know your limitations and be careful not to exceed them. The first rule is first do no harm. Next slide. And then we always have to think in terms of the present and the future. One of the most important things is to try to leave something behind that will help people in the future when they have the same problems. That's one of the big problems with all the short-term missions is so often we take care of a handful of patients, maybe we even leave some pills. The pills run out, there's no one to help with the next patient, and we're really not accomplished very much. Next slide. So the local staff, on the left is a healer in Ecuador, up high in the Andes, working with the Quechua tribes. And on the right is the very highly skilled staff we work with in Ambato, Ecuador. And the difference is night and day, because they have nothing up there in the mountains, but the other place they have excellent surgeons and some equipment. The most important thing I want to learn from this slide is never underestimate the capability of the local providers. This lady who's the local healer is actually practicing great medicine. When we look at the type of things she's showing them, what they're telling them, these are really medicines. They're things that actually are effective to do what she says they'll do for the locals, and they're things they can actually get. And then on the other hand, I'll never forget, I had a couple of operations I did with the taller general surgeon there, who was a senior surgeon. And so I operated, showed him how to do an operation, then he did the next one, and he probably did a much better job than me. He was, clearly a highly skilled guy, and he'd done this operation many times before. So we should be careful to recognize that some of these people are very capable with what they've got to use. Next slide. Urinary retention. This is an extremely common problem everywhere in the world. It can be acute or it can be chronic, and it's fatal if not treated. Deaths usually from renal failure or urinary sepsis. Acute urinary retention is extremely painful to the degree you think the patient's going to die, but it's not rapidly fatal. It'll take a long time to die. Unless the patient has sepsis, he'll die of renal failure, which can take weeks. Bladder rupture is very rare unless there's trauma or something accompanying it. Initial management is by catheter drainage. We'll talk about that more. It's more common in males than females. BPH, stricture, and neurogenic bladder are the most common causes. Next slide. So BPH, benign prostatic hypertrophy, is very common everywhere. The initial management is to put a catheter. Sometimes there's bleeding and clots associated with it. Usually it's easy to place a catheter, but sometimes the catheter won't go. If it's just a large prostate, a Coude catheter or a catheter guide can help, but some of these instruments require some experience. We'll talk more about Coude catheters in a little bit. Next slide. So this is an example of a urethral stricture, and there's a retrograde urethrogram accompanying it. Urethral strictures are classified by location and by cause. The location can be at the meatus, it can be in the bulbous urethra, it can be in the membranous urethra, that's where the stricture is. And the common causes are infection, trauma, iatrogenic, such as someone trying to put a catheter in and traumatize the urethra, or it can be congenital. Next slide. Let's see. These are some pictures of retrograde urethrograms. The very short strictures that you see indicate that they're probably caused by trauma and injury, because an infection usually leaves a longer segment of damaged urethra. A retrograde urethrogram is fairly simple to perform and requires very few resources. I usually like to put a small Foley catheter just inside the urethra, below the balloon on the catheter up, just enough to occlude the urethra, and then very gently instill contrast. Patient should be in oblique position. A single film shows exactly what you need. You don't have to have a cystoscopy or anything like that to diagnose these strictures. What you see is what you got, and this is enough information to proceed with surgical repair. Next slide. And this is an example of a urethroplasty to repair a stricture. So what we've got here is I first dissected out the area of the urethra that's injured, and then we remove a small segment. In this particular patient, we didn't need a graft or anything like that, simply sewed the end of the urethra back together, left a catheter in for a couple of weeks, and this solved the problem permanently. Often in these countries, a patient with a stricture has a suprapubic tube or just has it dilated and sent out, and then if it's dilated, they're going to be back in a month to have it dilate again. If it's a suprapubic tube, it has to be changed maybe every month or two for the rest of their lives. So if it can be repaired, this is far better. And this surgery can be learned by general surgeons, but most of them haven't got any experience with it. Next slide. These are some basic catheters. The one on top has 3 arms, so it can be irrigated continuously. The middle one has just a larger balloon, so it won't get pulled out easily. And the lower one's just a basic, the one at the bottom is just a basic catheter. And then there's just a picture of closed catheter drainage. This appears to be a sterile technique, but almost everybody is infected within a few weeks. A closed catheter drainage system like this is a very poor solution for long-term bladder drainage. And next slide. This slide's just about catheter placement. Usually it's easy to pass the catheter in, blow up a balloon in the bladder, and it drains fine. The biggest problem that occurs during placement is when the catheter is incompletely inserted, the balloon's blown up in the urethra, rupturing the urethra, and sometimes after that, nobody can get a catheter in. It can cause a stricture, lots of problems. So with a prostate problem, usually it goes in most of the way, hangs up. A Coude catheter can help get it in. With a stricture, if it's not too tight, a really small catheter may go in, but these may kink in the urethra. The important thing to know is unless the catheter is in far enough that urine's easily draining, you should never blow up the balloon because you can cause a lot of harm. Next slide. And I've outlined some problems with a chronic indwelling fluid catheter. In most of the places I've gone, the people I see who have retention simply have a catheter placed and they return to whatever healthcare facility they have and get changed every 4 to 7 weeks. That's just what we see. It's a terrible way to live. The catheters have to be changed frequently. They get encrusted with stones. Patients all have infection. Some of them get septic. Bladder stones frequently occur as a result. And the catheter can get displaced, ripping the, if they get pulled on, pulls the balloon into the urethra, and they have severe morbidity from that. Next slide. This is just a Coude tip catheter. It shows an angulation which should be pointed ventrally, and sometimes this helps get past an enlarged prostate. These come as catheters with and without balloons, the balloons if it needs to stay indwelling. Next slide. This is a set of urethral sounds. I saw this on Amazon, so anyone can buy this whole set for $35. Without really good experience, you can tear a urethra to shreds with one of these instruments. It really does take some training to safely use these. They're used to dilate strictures, starting with small ones and putting larger ones in through the stricture until it's big enough to pass a catheter. Next slide. This is a set of filiforms and followers. It's not that easy to see. The little tiny one is the filiform. It can be passed up to the stricture and then moved around gently until it goes through. If it's pushed even a little bit, that tip will perforate the urethra and create a false passage, making it very, very difficult to ever successfully get one of these through. If it passes smoothly all the way into the bladder, the followers, which are in different sizes, get screwed onto this the end of this, and can be used to gradually dilate the urethra until it's big enough to pass a catheter and leave it in. The important thing, just like the other instruments, is without a certain amount of experience, you can cause permanent damage to urethra. It really should have some training before attempting to use these. Next slide. This is a catheter guide. It's a stiff wire that gets lubricated and stuck inside a Foley catheter, and it can be used to angle the Foley catheter past an enlarged prostate. It should not be used to dilate a stricture. There's nothing magic about this. I've been in situations where I took a coat hanger and sterilized it, bent it to this shape, and used it as just a way to stiffen a Foley catheter so that it can be guided. This instrument should never be forced. It'll go right through the urethra. I've seen people pass these into the rectum, suprapubic area. But if you know how to use it, it can get a catheter in where it'd be otherwise impossible. Next slide. And this is something that's so greatly underutilized in the third world environment, and quite honestly in this country as well. Intermittent self-catheterization. It takes a very short amount of time to teach most people how to do this. Women can do it and men can do it. It simply requires the patient to learn how to pass a catheter in the urethra until urine comes out. They may have to do this 4 or 5 times a day. It means they don't have to go around wearing a catheter. Most people learn how to do this without hurting themselves. These catheters cost about $1 a piece. One catheter can last years if they're taken care of. So this clearly is a less expensive, less dangerous way to manage patients, and it's just not done very often in most primitive environments. An interesting thing I've heard is historically, gentlemen before Foley catheters and stuff kept their catheter in their hat band, lubricated it with tobacco juice, and just used this for catheterizing themselves. That's part of the American history. The point is that draining the bladder completely on a regular basis with a straight catheter is less likely to cause infections, complication, and sepsis than an indwelling catheter. Many of these patients don't have infected urine. Their bladder emptying completely takes care of it. Everybody with an indwelling Foley catheter has infected urine. Next slide. These are some reusable catheters. As I said, they cost about $1. Can be used again and again and again. We just tell patients to wash it off with some soap water, rinse it, keep it in a plastic baggie. It can be done in a primitive environment just as well. It doesn't have to be all that clean. That's a female and a male one. The male one also has a coude tip for those that find that easier. Next slide. Suprapubic catheter placement. So if Foley catheter will not go in easily, and particularly if you don't have experience using some of the specialized instruments, the safest thing to do is to place a suprapubic tube. It can be done with local anesthesia. It takes only a matter of minutes. They have kits that make it really very easy. Next slide. Slide. This is just an example of some of the kits that are used to insert these. They can be actually fabricated. It's not that hard to get a catheter and make your own kit with the stuff that can be found in most local operating rooms. And any surgeon can be taught to do this, or a surgeon can easily be taught to put an open suprapubic tube in with an incision. It's really simple surgery. Next slide. Transurethral resection of the prostate, TURP. This is the preferred management for retention from BPH. And most of the primitive environments that have good general surgeons, the surgeons don't have any experience doing transurethral surgery, and they can remove prostates with open surgery, but it's a very bloody operation, and it doesn't give as precise a result, but that is what's available in most places. Transurethral prostatectomy uses almost no resources that aren't reusable, and it can be taught. In the United States, we have evolved into using lasers and ultrasound and radiofrequency and a variety of other techniques to remove prostate tissue. None of these have been proven superior. Some of them take less skill, and all of them are extremely expensive. So a simple monopolar transurethral prostatectomy, like has been done in the United States for over 50 years, is the best alternative to manage a patient, so that they won't have to keep coming back and getting a catheter changed or anything like that. Next slide. I just wanted to mention this case that got my attention. In Honduras, we had a patient who had retention. He came in, he said he had continued to void spontaneously, but this has just recently stopped. He said he had prostate cancer and been treated with radiation chemotherapy. We had a good interpreter. He was also a physician that gave this history, got this from him. We tried every trick in the book to get a catheter through him, and then finally had to put a suprapubic tube in. The problem was he didn't have prostate cancer. He had rectal cancer. He had a fistula and had been voiding out his rectum for the past few years. And the reason I brought that up is to mention that records and accurate history are so important and so difficult to obtain in these countries. The patients don't know what's been done. They have no records. There's no records available anywhere, and it can lead to a variety of pitfalls. Next slide. Urinary tract infections. We're all familiar with dysuria, urgency, frequency, suprapubic pain, sometimes hematuria. Urinary tract infections do get better on their own most of the time. They don't stay there for the rest of the patient's life, but they get better a lot more rapidly with antibiotics, as everyone's aware. They usually don't cause a fever unless there's involvement of kidneys or prostate. So if someone has a urinary tract infection and a fever, there's something more complicated going on. I think it's reasonable to give antibiotics based on history of the dysuria, suprapubic pain alone. Most of the undeveloped countries don't have the antibiotic resistance that we see, so Bactrim is usually the best choice to start out with. Next slide. This is just a small basic lab. Most important thing, or the easiest thing to use, is those dipsticks, because they give a tremendous amount of information with just a stip that costs about 10 cents. And so it's a good thing to travel with. You can diagnose an infection with reasonable probability. You can find blood in the urine and so on. So we do use those. It's nice if there's a microscope. A lot of places don't have a microscope and centrifuge and those things. Cultures and sensitivities are almost never available. And even if they were available, patients are usually there and then they're gone into some primitive area that they don't get back to, and the results aren't available for a few days. So we almost always have to treat infections empirically in these environments. Next slide. Ultrasound is becoming much more widely available and really makes life so much better. You can diagnose retention, kidney stones, hydronephrosis. I think any patient who shows up with a fever and an infection, if you've got an ultrasound, it's a great idea to see if they've got some complicating features such as retention or hydronephrosis. Important thing to know about an ultrasound is the equipment's very secondary to the skill of the person using it. So next slide. Bladder stones are extremely common. They're usually the result of chronic retention, sometimes the result of a chronic indwelling catheter. We see bladder stones in primitive environments that are much larger than anything we see in this country. They usually have pus in the urine, blood in the urine, difficulty voiding. You can see them pretty well with the bladder ultrasound. Cystoscopy, of course, gives you a certain diagnosis if you've got that. KUB isn't quite as good because you can't quite be sure most of the time. In the United States, these are treated with a lithotripsy, but usually in limited resource countries, open surgery is required. It's easy surgery, but usually have to operate on these patients. And then it's always important to recognize that some underlying problem, such as obstruction, needs to be corrected. They'll just get the problem again. Next slide. And so these are some stones I removed from a couple of different patients, just showing how big they get to be. And next slide. This patient has a bladder stone, and it can be seen there in the pelvis, but that easily could be something else. And so something other than just a KUB is necessary to be certain. An ultrasound would be adequate to clinch the diagnosis, but you'd hesitate to make an incision and open up the bladder to look inside with just a plain film like this. Next slide. And this is a stone that we found on ultrasound, and I did a cystoscopy, tried to get this out, and it just was too hard to break up. And so I had to open the patient up, and I peeled the crust off, and this is what I found. This is a bullet. This had been in his bladder for 14 years. He'd been shot, and some bullets had been removed from his intestines, but they didn't know about this one in his bladder. So I just thought I'd show that. Next slide. Kidney stones. So in the United States, the past 20 or almost 30 years, I've not needed to make a incision for a kidney stone. But in other countries, they just don't have ureteroscopes and lithotripsy and all the things we have. In the United States, diagnosis is generally made on a CAT scan, but most places that we're looking at don't have a CAT scan. So what we have to do is open surgery, just as was done back in the 1970s and 80s in this country. Next slide. Now, one would have to hesitate to cut a patient open without knowing exactly where that stone was. So there's no CAT scan most of the time, but an intravenous pyelogram is a very easy procedure to do. This is the X-ray developing equipment that we used and the old developer for films that we had in Loma de Luz at Honduras. Next slide. And this is an intravenous pyelogram that shows a stone obstructing the right kidney. And there's the stone removed, and that's the size of the incision that was required to do this. It's a big incision, but that stone's in very deep, and there's just no way to get to it with a tiny incision using the instruments that are available. Next slide. That's another stone. It looks pretty obvious on the plain X-ray that that is a stone, but we did an IVP because I want to know exactly what the urinary tract's anatomy is. You may notice there's a second stone in the lower part of the right kidney that it's nice to remove both stones if you can get to them. Stones in the kidney are very difficult to get to with standard instruments, but it's worth trying. Next slide. And this patient came to us with a CAT scan, particularly in Honduras. Their patients can get a cheap CAT scan in town, but they can't afford any surgery. There's not capable surgeons. If there were, they haven't got the money to pay for it. I usually discuss with people like this the option of going to where they can get a lithotripsy or something else, but they always say they can't afford it. And frequently they say that they have more trust in the Christian surgeons at Loma de Luz. So we remove these with old-fashioned open surgery. Next slide. This is a pretty good sized kidney stone that probably would have required open surgery anyway. And that's just a picture of the stone and the incision that was necessary to get that out. Next slide. And this was a staghorn calculus. In the United States, we'd have probably done a percutaneous procedure and tried to clean all these little stones out of this kidney and everything. But the patient had a second kidney, and where we were working at this time with the resources and the ability to do repeated operations just didn't exist in it made more sense to remove the kidney. Next slide. So testicular abnormalities, I'm going to go through this fairly quickly. Hydroceles, spermatoceles, hernias, epididymitis, torsion, even testicular cancer. In the United States, we do a lot of fancy tests, ultrasounds, and scans and things to evaluate these, but these diagnoses can all be made with pretty good reliability on physical exam. And these problems can usually be fixed, other than maybe a big hernia, with a local anesthetic, a block of the spermatic cord, and you get complete anesthesia of the testicle. You can remove a testicular cancer, fix a torsion, certainly take care of a hydrocele or spermatocele without a general anesthesia and without any advanced testing of these. Next slide. And this is a testicular cancer that was evaluated on physical exam and just removed. There's enough confidence in the diagnosis to proceed without any other testing. This testicle was given to the patient in case they were able to get a pathology report. I doubt that they did. It's not generally available in these places. Fortunately, surgery is probably curative for this patient, but I don't have any follow-up or anything. Next slide. Now, the penis, infections, phimosis, cancer, fractures, Peyronie's disease, circumcision, all these can be managed with a local block of the penis. General anesthetic isn't necessary. A little xylocaine at the base of the penis blocking the nerves in the dorsal area and around the urethra is adequate. One thing I did want to mention is circumcisions becoming more popular or recommended because of the AIDS problem. Men who are circumcised generally don't get AIDS from sexual contact, and uncircumcised men frequently will. So as a AIDS preventive measure alone, circumcision is not a bad idea. Next slide. Genitourinary cancer. Kidney, bladder, prostate, testicle, and penis. Those are the common ones that we deal with. Next slide. Kidney cancer. I wanted to mention this because in the United States, we see a lot of kidney cancer incidentally on CAT scans. We're seeing some of that in third world countries. Previously, anyone thought if you see a cancer, you take it out. But the fact is that current data shows that small tumors usually cause no problem for many years and often don't grow at all, or not more than a millimeter or two a year. And so partial nephrectomies like we do here are generally not appropriate. And usually we don't find small tumors in third world countries like we do here in the United States. Usually we find big cancers that you can feel, cause pain and bleeding, and these usually require complete removal. Next slide. So this is just a kidney cancer that I removed in Honduras. This was kind of an interesting story. This lady came in with the CAT scan that she'd gotten in town because she's having a lot of abdominal pain, and this was a palpable cancer. This was easy to feel on physical exam. This lady was 80, and she looked like she was in bad shape. No one wanted to operate on her, and we really considered not operating on her because of her aging condition, but it was a painful cancer. And I discussed this with Dr. McKinney, who's the founder and head of Hospital of Toulouse, and he said he votes for life. So I said, well, we'll do it. And it turns out this kidney cancer almost jumped out of the patient. It took about 45 minutes, no blood loss. And amazingly, the lady was up walking around, said she felt great the next day. She went home without any medications 2 days later. So, well, we have to remember we have limitations. There's sometimes you just have to move forward with confidence. Next slide. Bladder cancer. So bladder cancer usually presents with blood in the urine. It is a difficult diagnosis to make without cystoscopy. You can suspect and see a mass or something on ultrasound if it's big. But it's very difficult to know that you should open a patient up and do something without a confirmed diagnosis. Ideal management, usually easy, is a cystoscopic transurethral removal. But if you have a diagnosis of this, it's not wrong to open the patient up, open the bladder up, remove a piece of the bladder, burn it off the bladder. It will stop the bleeding and it can cure the disease. It's just not what's normally done in developed countries. Next slide. Prostate cancer is very different in developing countries than we've been led to believe in the United States. In the United States, there's a big push for early diagnosis and cure, PSA screening, needle biopsies, radical prostatectomies. But even with all this technology, there's a great concern that the treatment's causing more harm than the good, that very few patients who will die of the prostate cancer are cured. Usually you either have a prostate cancer that's indolent and is not going to kill you, or you have one so aggressive that nothing's going to cure it. So in underdeveloped countries, it makes absolutely no sense to do PSA screening, early treatment of prostate cancer. Every once in a while, someone shows up with an elevated PSA, but it makes almost no sense at all to do anything about that. The patients that we see with prostate cancer usually present with obvious advanced disease. They've lost weight, they've got bone pain, you do an x-ray, you see metastases, rectal exam reveals a huge fixed prostate. Usually there's no pathology available, and we do bilateral removal of the testicles to treat these patients. The drugs and stuff that we use just aren't available to these people. Next slide. Kidney trauma. Kidney trauma is classified as blunt or penetrating. An important thing to know about kidney trauma is that the vast majority of these patients will get better without any intervention, and usually have a better result if it's left alone. It can take some time. And the other thing to know is before going in to operate on a patient with kidney trauma, it's really important to know if there's another functioning kidney, because the most likely outcome in a third world country is nephrectomy. And so it's hard to get a result by surgery that's better than somebody can get without surgery. The other thing to know is once you operate on a patient like this and open up the area around the kidney, they bleed a lot. And if there's no blood bank, it's possible to have a really bad outcome. Next slide. Bladder injuries. Bladder injuries also can be bladder penetrating. Usually if there's a perforated bladder, you're better off with a surgical repair, although they can get better with catheter drainage alone. If the pelvis is fractured or the urethra is damaged, usually a suprapubic tube is the best choice. Next slide. Next slide. Oh, penile injury, great. So penile injury can be penetrating or blunt. If it's blunt, frequently a catheter is good enough. A penetrating penile injury should probably be repaired. It's usually easy. A circumcision session, degloving the penis and putting a few stitches in is probably all that's necessary. If the urethra is damaged, a catheter is appropriate for a couple of weeks also. Next slide. Testicular injury. Scrotal hematoma can be managed non-operatively or can be drained, but a ruptured testicle should be suspected and surgically repaired. An ultrasound can show a testicular rupture if you've got that available to you. Next slide. These are just some basic urology instruments that are used for transurethral prostatectomy. What you see there is about all that's needed. They can be sterilized by simply soaking in solution and get used again and again and again. Next slide. And then we combine that with locally available materials. We fabricated the irrigation system here so that we could do this prostate surgery. This one, I think, was at Loma de Luz. Next slide. And this is a flexible cystoscope. These are great instruments to have. It makes diagnosis possible with local anesthesia without much discomfort. But the big problem is these things are really delicate. They break easily. It costs about $10,000 to replace. And if one of these is donated to a primitive environment without proper education of maintenance, it probably won't be around very long. Next slide. Sterile processing is important. And I have a picture of a sterile processing unit on top in Honduras, which is a pretty nice little hospital. And then the lower one is in Portuguela, Bolivia, where everything is washed with a scrub basin, hung to dry, packaged, put in the autoclave, and used again the next day until it's just absolutely useless. Next slide. And I just wanted to throw in a few pictures of Honduras and Loma de Luz because we've worked there many times. This is a picture of the hospital. That's Bridgie and me on the beautiful grounds there. And this is a really nice modern operating room. Next slide. And there are some 5-gallon bottles that we sterilize solution in the autoclave for our transurethral surgery. And you see a fabricated tower that we use to give us 5 gallons of irrigating solution, allowing us to do the entire surgery without having to change any tubing or bottles or getting air in the system. Next slide. And that's just the couple pictures of a transurethral prostatectomy that we started to do down in Loma de Luz using that equipment. Next slide. And the blood bank. At Loma de Luz, they have a walking blood bank, which means they have about 100 of their staff, which have been typed. And when they have a problem, they call in the appropriate staff and collect blood. This is Bridget giving blood to a gentleman, or for a gentleman, who showed up with a hemoglobin of 3 after years of blood in his urine. We did a cystoscopy, found a large bladder cancer, and he was managed with an open partial resection of that bladder cancer by the local surgeons because this all occurred when I was getting ready to leave the area. Next slide. And this is just a picture of Mango, Togo, where we went with World Medical Mission for their surgical specialty team back in May. This is not a very primitive environment, but because it's in a primitive area, they haven't got as many resources. They make their own IV solutions with pretty modern equipment. So you can see there the bottles he's preparing intravenous solutions for the patients. And then in the lower right-hand corner, we created a mechanism with just some stuff we found sitting around so that we can have continuous flow of irrigation solution for transurethral prostatectomies. Next slide. And so I have just a few take-home messages. Understand the available resources. Always know your limitations. The urine dipsticks can be taken anywhere. Teach intermittent self-catheterization rather than giving patients indwelling Foley catheters. Basic skills from the 1970s are still usable in these environments. Try to use local and regional anesthesia. And always remember, the education you leave behind has the greatest lasting impact. Next slide. Reuse everything: drapes, tubes, electric cords, resection loops. These places can't afford to buy new stuff. Next slide. And very importantly, teach the local physicians and staff. This is a family physician in Honduras, and we were actually removing an infected bullet from this guy's penis, and I was having him do the surgery, showing him how to do it. Next slide. Questions?
Reminder, this is just a reminder to anyone who does have questions, go ahead and post them in the chat. Thank you very much, Dr. Boll. That was great. I guess my first comment is just to add to the urethral sounds, we found them quite handy to use those to dilate tracheostomy strictures as well. So having those handy in the hospital are quite beneficial. So as you mentioned, you hosted or were actually the main surgeon on the first surgical subspecialty team to Togo. And we want to thank you for that. Is there anything more that you found on that trip that you'd want to comment about?
Well, I think we were highly successful. And the reason I think that is because we did a lot of surgery, but we left the long-term general surgeons who are staying at Togo with the ability to continue doing that surgery. And by the time we left, they had already scheduled up weeks of urologic surgery that they were unable to do before we had gone. And World Medical Mission donated the equipment so that they could do that. So, that's the critical thing in these places, is to leave behind a continuing capability.
Yeah, what a blessing to bring the equipment to teach them how to do the procedures and then be able to leave them with some equipment to carry on after you're gone. So that's great. I think we don't have any further questions. I sure appreciate your time. A few notes is that, remember, CME credit is available for this session. The form and instructions are in your email. We will be sending up a follow-up email with a link after this recording. If you're not on our email system, you can join the forum, and there's a button that you can click to join the forum at health.samaritans.purse.org. So that's health.samaritans.purse.org, and be the first to know about upcoming events. Finally, our next webinar is Wednesday, November 13. Tim Mosher will present at that time, and be sure to join us at that time. Again, thank you very much, Dr. Bohl. I see no further questions that have come about, so I just appreciate your time, and if there are anything else, I'm sure we'll be in touch in the future.
There's one question on the board I see. I'm just looking at the chat box. And somebody asked why I think everybody is so hesitant to promote intermittent self-catheterization. I don't know if I should respond to that, but I did see it there.
Great. Please do.
And that's a tough question, but it requires some teaching. And in an emergency room situation, normally they just put a catheter in and send the patient out. If maybe another 10 minutes or 15 minutes is spent, and that patient's taught how to catheterize themselves, it makes a huge difference. But the local people just haven't been instructed to do that.
That's very interesting. From my perspective, being an ENT doctor, I had no understanding of the long-term treatment. So I assumed that was the standard of care, was to place a catheter, and they just had to keep that long-term. And the relative ease of doing intermittent catheterization seemed amazingly beneficial, preventing the long-term risk of leaving an indwelling catheter in place. Good. Anybody else? Anything else that you see there, Dr. Bohl, that I'm not seeing?
Nope.
Great.
I don't see any other questions. Thanks. I don't know why I got that one before you did, but there it is.
Fantastic. Thank you again for hosting today's event.
Thank you.